Hey guys, so I'm going to do something a little bit different for this month's training. I'm going to bring you a little class on hypothermia. I figure going into the winter months, we're starting to see some, several frosted mornings, so we're going to have a greater likelihood for the next several months of seeing some hypothermia cases. So a good time to refresh on this, since it's something we don't deal with year-round. So there's a few things that I want to try to cover. Made a lot of notes, just bear with me. I thought it would be easier on myself and on you guys to do a little video than it would be to try to put together a PowerPoint and bore you to death just flipping through slides. So hopefully I'll do a good job of relaying this information to you so that you can answer the questions on the quiz that goes along with this, and be an easy way to get an hour or so of Con Ed credit. So in this lesson, I want to make sure that you understand the 4 ways that the body loses heat, the different stages of hypothermia, and how to treat those. So hypothermia in general is classified as a core temperature of less than 95 degrees Fahrenheit. Now, homeostasis in our body requires roughly a temperature of 98.6 degrees. We all know that that's the recommended or ideal body temperature. If the body temperature varies from that much in either way, that homeostasis is going to be disrupted. So in order to maintain that, our body's heat production has to balance 4 different mechanisms of heat loss. Those mechanisms are convection, which is simply the body heat being lost to surrounding air. So as I'm standing here, the heat from my body, especially my exposed skin and my head, is dissipating into the air around me. That air becomes warm, which causes it to rise. It is replaced with colder air, and that cycle continues. So then we have conduction. Conduction is actually me physically touching a nearby object. My skin or clothing coming into contact with a nearby object is going to cause heat loss through conduction. Radiation is actually a little bit confusing. It's similar to convection in that I'm not having to touch anything, but rather than just the heat dissipating into the air, standing this close to this board, for say, my arm's about 4 inches away, the heat will actually radiate from my arm, which is a warmer surface. Remember back to science class that heat travels from the source of hot to cold. So from my body heat, heat will radiate to any object within whatever distance that is cooler than my body temperature. And then our 4th and final way is through evaporation. Of course, evaporation, again, returning to science class, is the act of turning a liquid into a vapor. So the way that the body does this is when we sweat, that's our body's way of cooling ourselves. It does that by that evaporation, turning that sweat into a vapor. And then also, regardless of what temperature it is, we have our respiration. So when we walk outside in the cold and you breathe out and you see this fog, that's because of evaporation. That liquid that's in our lungs is turning into a vapor as it leaves our body. And there again, another way that we lose our body heat. So we know how we lose heat, but how does our body compensate for it? So to start with, all these are going to be involuntary things that our body automatically does as long as it's functioning properly. Your metabolism is going to increase. This is going to increase your heart rate and your respiratory rate also. Your body's going to start shivering. All those involuntary fine movements of your skeletal muscles, that's going to help generate heat. Vasoconstriction in your skin and in your extremities is going to help pull a lot of blood into your core to keep the warmer blood in your vitals, all in your torso and in your head. And that also is going to help insulate a large portion of your blood from the cooling effect of running through your extremities by evaporation and other means. And then, of course, we have our voluntary things that we automatically do. Think about when you get cold. What do? You're going to look for shelter. You're going to try to find some warm place to get, right? You're going to put on warm clothing or a blanket. You may consume warm liquids or warm foods. I know I really like coffee in the wintertime. Not so much to keep me warm, but that's another story. You're going to engage in physical activity. So what do you see people do a lot of times, especially when they're standing out in the cold? You know, they may put their hands in their pocket, jump up and down, they may rub their hands together, things like that. These are all things that we automatically do without really thinking about it, but it does require voluntary muscle movement. And then, of course, something as simple as changing your position. You know, if I'm outside and I have a hood on and I feel wind hitting my face, what am I likely to do? I'm going to turn to the side, right, so that wind's not hitting me. Or say if you bend over, your shirt comes up a little, you feel that cold wind across your back, what do? You're going to stand up and pull your shirt down. So keep these things in mind in just a few minutes, and we'll talk about why those are important. Now let's talk about the classifications of hypothermia. So there's actually, according to our INSEP document, there's 3 different classifications. Mild hypothermia is considered from 90 to 95 degrees Fahrenheit. Moderate is going to be 82 to 90, and severe is anything below 82 degrees Fahrenheit. And again, these come straight from our INSEP document. I know this will probably show it backward to you since I have the video on selfie mode, but if you'll look right there, kind of shows those. And if you'll look where you click on this video in Brad Goodman, I'm going to actually attach a copy of this INSEP document along with a couple other things that you'll see there to kind of help you as a reference. So we know what hypothermia is, what the classifications are, but let's talk about the physiological effects, why it does what it does. So hypothermia affects every organ system in our body. The central nervous system is actually initially protected, but then it actually becomes depressed as your body temperature falls. So you're going to start out, when it starts affecting your central nervous system, seeing slurred speech, some confusion, impaired judgment, and amnesia. Then it's actually going to progress from a lethargic state into a comatose state. And then your reflexes are going to disappear altogether. Your central nervous is going to stop regulating your cardiovascular system, and then we'll talk about what that will actually lead to in just a moment. So these cognitive symptoms actually prevent your patient from taking the actions necessary to save themselves. So these things that we talked about were voluntary. Now these patients aren't able to do that. In your moderate to severe hypothermia patients, greater than 20% of these in studies actually show that the patients, once they get to a certain point, actually start feeling this warm sensation, and they actually start taking their clothing off. And I'm sure at this point it's probably not an intended thing. They don't even realize they're doing it. But so if you run a patient that you suspect would be hypothermic in a cold environment and they've taken their clothes off, go ahead and assume that this patient is at least in a moderate, if not severe, hypothermic state. Whether or not they immediately present the symptoms or not. So let's talk about that cardiovascular effect now. We've said that the neurological system, once it gets to a certain point, will stop regulating the cardiovascular system. So with mild hypothermia, you're actually going to see an initial increase in your heart rate, your cardiac output, and your systemic vascular resistance. They're all going to spike, but then after that initial spike, you're going to see a steady decline, almost linear, of your heart rate Once you get down to about 82.4 degrees, you're going to see about a 50% decrease in the heart rate. Once it gets to that point, atropine is probably not going to do any good in these patients, because your decreased heart rate is actually a result of a slowed cellular metabolism at the SA node. So it's not going to have any effect with atropine in these patients. And then as that hypothermia progresses, you're going to see a corresponding drop in your blood pressure and your cardiac output. As far as your EKG, initially you'll see prolonged PR, QRS, and QT intervals. At an initial glance, when you look at it, you may think, well, this is a first-degree block. But if you'll look a little closer, you'll see that all of these intervals are actually prolonged, not just that PR. As it progresses, you may see what's called a J wave or an Osborne wave. I will attach a picture of that also with the rest of these files so that you can see. I may put a couple different ones in there. But on the downward slope of your QRS, before it gets back to the J point, you'll actually see, I call it like a false J point. A little bit higher up on that downslope, you'll see a little J or a notch develop in your QRS. As your hypothermia becomes worse, the depth of that notch is likely to become deeper. So remember on these patients though, your EKG is probably going to be pretty hard to obtain. Initially, your patient's going to be shivering when they're in that mild hypothermia state. So this is going to cause a lot of artifact. Once they get into the moderate to severe, they'll probably stop shivering, but then at this point, their skin essentially is frozen. It becomes very hard, almost waxy. So it's going to be hard to get your electrodes to stick. So keep these things in mind. Obtaining a 12 lead, it may take a little time and patience to get it right with these patients. So once you get into that moderate to severe category, you can really see any kind of arrhythmia on the monitor. Most of these are not going to require any treatment because as you warm your patient, it'll actually correct that problem. Spontaneous VFib is pretty likely once you get into that severe category. Once you cool that cardiac muscle below 82.4 degrees, your myocardium becomes so sensitive to any kind of trauma. So just something as simple as moving your patient onto the stretcher. If you're not really careful, that can actually induce VFib in these patients. So you have to use a lot of stress a lot on being careful when you're moving them. Now, your respiratory system is going to respond a lot like the cardiovascular. So initially, you're going to see that increase in your respirations, and then it's going to be followed by a decline. If it's severe hypothermia, the respiratory drive from the brainstem is actually going to be shut down. And then on top of that, all the tissue in your chest and your lungs is actually going to stiffen because of the cold. So hypoxia is something that you're going to have to battle in these patients. Again, once you increase that body temperature, this is going to correct itself, but it's something you may have to deal with while this patient's still hypothermic. Okay, so now we kind of understand the physiological effects. Let's talk about some special patients that are going to be exceptionally prone to becoming hypothermic. The first one that most of us think about is going to be our elderly patients. So with these patients, one thing we have to think about is they already have a decreased ability to compensate for the cold. They may not shiver like we do. They may not have that initial increase in their metabolism, in their heart rate and respiratory rate like we do. Because of that, they're going to be much more susceptible. They can actually just be simply sitting in a recliner in their home. And you think about Our ideal body temperature, we said, is 98.6 degrees. What's ideal room temperature? It's about 72 degrees. So we're over 26 degrees difference just in our ambient air. Without these compensatory mechanisms, our elderly patients can become hypothermic just simply sitting in their living room. And then when we add on top of that, how many falls do we run with our elderly patients? It's the primary volume of the falls that we run, right? Well, what's the temperature of this hard floor that they're laying on? If our room temperature is 72 degrees here, it's likely 65 or colder down there. So now we're 30-some degrees colder than our body temperature, and that's what these elderly patients are laying on. So their skin against that cold, hard floor is going to dissipate heat much quicker than it is standing or sitting with the ambient air around us. So these patients are going to become hypothermic much faster than someone that's simply sitting in their chair. Now, our second group is going to be our neonates. Whether you realize it or not, neonates don't actually have the ability to shiver. So they're automatically out that, and other compensatory mechanisms that we're equipped with, they simply haven't developed yet. So that's why it's so important to keep these babies covered up, bundled up in blankets and things like that when it's cold weather. And it just really gets under my skin to see, mom and dad out bundled up and have their baby out in a diaper. But I'm not going to get on a soapbox about that, but they don't realize how fast these babies lose body heat in compared to us. And on top of not having the compensatory mechanism, they also look at the size of their body. Proportionately, they have a much larger surface area than we do, especially in their head. It's a lot more skin showing to the ambient air, so they're going to lose heat that much faster. Now, our third group of special patients that we have to look out for is our trauma patients. And this may be the main one that we see as far as our hypothermia goes. So there's been some various studies, and they show anywhere from 29 all the way up to 66% of major trauma patients actually have at least mild hypothermia by the time they arrive at the emergency department. Think about the injuries that we see in these patients. It can damage the central nervous system. They can suffer from burns, major bleeding. Along with that major bleeding, what kind of wound is causing that? Is it an open wound that creates more surface area to lose heat from? And then, of course, shock. All of these things actually affect our body's ability to rewarm itself. And then, on top of that, what do? We get to the scene, we start cutting clothes off. So we strip the patient down to expose them to more cold, put them on either a hard backboard or a cold mattress pad, and then force them to lay still. So I know we have to do these things to fully assess our patient and to do what we feel is in the best interest for them at the time, but keep in mind the fact that they're probably already somewhat hypothermic, and we want to prevent this as much as we can. So take an extra second to take a blanket out of the cabinet of the truck, lay it on the backboard before you put the patient on it, or lay it on the mattress over top of the sheet before you put your patient on the mattress. And then, of course, take extra blankets and cover them up. It's just going to take a little extra care on our part. Now, for this presentation's purpose, I am talking about accidental hypothermia, not induced due to cardiac events. With accidental hypothermia, there's two basic types. Your primary is what most of us think about, and that is simply the exposure to the cold. The secondary is actually can compound the primary, if you will. So the secondary is actually caused to a condition that's either going to disrupt the body's ability to produce that heat balance that we talked about, or actually decrease the body's capacity to generate or conserve heat. So here's what I'm talking about. Things like burn patients, patients that already have hypothyroidism, hypoglycemia, a trauma patient, somebody that has a CNS, central nervous system injury, stroke patients, septic patients, and how about this? Somebody that's having cold IV fluids infused, an alcoholic, somebody that's drunk, cannot maintain their own body temperature. They don't even realize they're cold most of the time. So a lot of these you'll run, in the cold weather months that don't realize they're cold, and they lay out and get frostbite or become hypothermic or both. And then some medications will actually reduce the body's ability to do this also. Things like sedatives, antipsychotics, oral diabetic medicines, beta blockers, and I'm sure there's others. Think about how many patients are on these types of medicines. It can be anybody, right? Any age group, it doesn't matter. So we need to be especially careful this time of year. All times of year, hypothermia is possible, but especially as we go into these colder months, to pay special attention to these patients like this. And keep in mind that your patient can present with almost any chief complaint. You may not go out for hypothermia. Most likely you won't. You'll probably go out for a trauma, for an altered mental status, a diabetic, a stroke, a number of things. You can get paged out for any kind of trauma or any kind of medical condition, and on top of that, find the hypothermia. Whether the hypothermia is caused by that condition or whether that condition is secondary to the hypothermia. Either way, pay close attention, make sure you're doing adequate assessments on your patients. So now, the part that all of us in EMS want to get to is, how do we treat these patients? So, as a general rule of thumb for all hypothermia patients, our first priority is common sense. Get the patient out of the cold. Move them into the back of your ambulance or into a warm environment. Make sure the heat's turned on. Put blankets on them. If they have any wet or cold clothing on them, take that off. Replace that with the warm blankets. If your patient needs an advanced airway, if it is indicated, don't withhold that. If you have the skill that you should have in placing an advanced airway, you are not going to cause enough movement of that patient to induce any kind of fatal arrhythmia that's not already present. So if they need that advanced airway, by all means, do that secondary to your warming measures. Now, let's talk about the treatment specifically for the different classifications of hypothermia. In your mild hypothermia, you're going to start with that passive rewarming. Again, getting them in the warm environment, making sure the heat's on, putting blankets on them, things like that. Go ahead and get a 12 lead in these patients. You're not likely to see a lot of real crazy rhythms, but you can see either that initial spike or the patient starting to become bradycardic. Either way, go ahead and get this trending 12 lead. Avoid administering IV fluids to these patients that are cold or even room temperature. Again, what's room temperature? 72 degrees. We don't want to put 72 degree fluid in a patient that's already becoming hypothermic. If our body's supposed to be 98.6, and we said that once you get down below 82, you're in severe hypothermia. If this fluid is not on a warmer, you're going to induce hypothermia even more. So withhold those fluids unless you have them on a warmer. Once you get into the severe, moderate and severe hypothermia patients, you're going to go ahead and take all those above steps that we talked about for the mild hypothermia. And then also, with these patients, you want to place hot packs in the axillary and in the groin. Warm the core, the torso area of this patient. You can even put them behind the neck, under the back, on the chest, things like that. When you have hot packs in place, I will say, make sure you constantly reassess, just every couple of minutes. Some hot packs I've seen in the past become hot enough that you don't want to touch them with your skin. The ones that we're carrying right now, I don't see an issue with that, but just in case, you never know, they might have put too much of whatever that active ingredient is from the factory. Just go ahead and reassess as a safety precaution. If you feel that getting too warm, you may want to wrap it in a washcloth or something like that to avoid the direct contact with the patient's skin. So here's something that I found in my research on this that I thought was pretty neat. So, you know, we hear all the way back to basic class that our locations for putting those hot packs, right? Well, one thing that I learned in my research, if you warm the extremities first, not only is it not as effective in warming your core vitals, right? It's also, if you warm your extremities first, it can cause vasodilation out here, which all this cold blood that's now sitting in your extremities, those veins expand, it lets that cold blood rush back to your heart, which puts it through the circulatory system, which actually then further induces hypothermia. So it's going to cause just the opposite of what we're looking for if you do that. So always, for the benefit of the patient, put your hot packs in the axillary and in the groin. And then, of course, on these patients also, if you have the option of warm fluids, make sure you're administering warm fluids. Ideally, at 104 degrees or above, but anything body temperature or above will work, of course. So let's talk about the EKG just a little bit more. You can see, especially in your moderate to severe patients, any number of arrhythmias. It can honestly be anything from AFib to simple bradycardia to VFib and anything in between. Don't get hung up on them. If it's not immediately life-threatening, if you warm this patient, chances are those arrhythmias are going to subside. So don't get blinded when you put this patient on the monitor. If your patient's unresponsive, because the respirations and the pulse rate is likely to be so slow in these patients, assess your patient for a full 60 seconds before starting CPR. This will avoid any unnecessary compressions. Again, we said this myocardium is going to be very sensitive to any kind of trauma. So if it's not needed, we don't want to go pumping on the chest, right? Make sure that the patient does need it. If they are in VFib, go ahead and do CPR, administer 1 milligram of 1 to 10,000 epi, and deliver 1 defibrillation. If that defibrillation is unsuccessful, in these patients, it's acceptable to go ahead and call medical control, advise them of the situation, what you've done, and ask for orders to withhold any further defibrillations until after you have performed the warming measures necessary to get this patient's core temperature up. Once that core temperature is up, if you need to at that point, you can deliver another defibrillation, and it has a greater likelihood to be successful than that first one did. But there again, because that does deviate from protocol somewhat, even though it does say that specifically in the pearls, if you will look at the back of the hypothermia protocol, it says contact medical control for this. So there again, you're deviating from the cardiac arrest protocol, just call and get orders to cover yourself. And keep in mind with these patients, I know you've heard the saying that your patient's not dead until they're warm and dead. Why is that? It's because once your body temperature gets below a certain degree, you're also cooling the brain. Because what do we fight with CPR in a non-hypothermic patient? If you have a large downtime when we get there, even if we get something back, what's missing? Usually it's brain function, because that brain has went so long without oxygen. regardless of what the rest of the organs do, if there's not been ventilations performed or adequate CPR performed within a certain amount of time, and we do get the patient back, they're likely to see neurological deficits. Well, with your hypothermic patient, when that brain cools along with the rest of the body, it actually helps protect that brain against a lot of those things. So there's some documented cases of CPR going on for over 6 hours until the patient gets back to above an 86 degree, I believe it is, body temperature, and regains pulses until they're placed in an ICU and eventually discharged with very minimal neurological dysfunction once they leave the hospital. So keep this in mind as you're doing CPR on these patients. They're not dead according to the pearls in our protocol until they have a body temperature of 93.2 degrees. So if you run a patient that's extremely hypothermic, you may not ever get them up to 93 degrees. You may be doing CPR a long time, all the way to the hospital, and transfer care over, and they eventually come around at the ER. So don't give up on these patients. They can last a long time with CPR being performed. So again, this is something different. I thought it would be a little bit more beneficial than flipping through a slideshow, but I hope you enjoyed this. Let me know if you like this kind of thing. I'll continue doing it if you do. But again, everything that's in the quiz I've talked about here. So go back and watch the video if you need to. Be sure to pull up the files, the hypothermia protocol, and along with the image of the J-wave so you can see what I'm talking about there. Hope you guys enjoyed this, and I hope that I was able to deliver it in a way that you can learn from it.